Theory is a piece of evidence that is important in the selection of assessment tools and intervention. Theories are a collection of concepts, definition, and hypotheses that help occupational therapists make predictions about relationships between events. Theories are a frame of reference, conceptual models, and practice models. The Allen Cognitive Disabilities Model, CDM, was created by Claudia Allen, an occupational therapist that saw the challenges faced by some of her patients suffering from mental disorders when performing regular activities. The Allen Cognitive Level Screen, ACLS, was developed by Allen and her colleagues as part of the CDM with the purpose of creating a series of activities that were equivalent to sensory motor functions and performance expected. The cognitive levels were conceptualized as a hierarchical sequence of sensory motor abilities similar to the development levels of cognition described by John Piaget. The construct of functional cognition has since become a useful term for describing the focus of concern of cognitive disabilities model. The focus or central idea of the model is the functional cognition patients. The concept of functional cognition is used to help clinicians better understand and describe the hierarchy of cognitive abilities of individuals and also describe the relative difficulty of task. Cognitive functions. Memory is described as the ability to register, retain, and recall past experience, knowledge, and sensation. Executive functioning is described as the mental process that enables us to plan, focus attention, remember instructions, and juggle multiple tasks successfully. It's composed of a set of interrelated core skills, including working memory, inhibition and flexibility, and initiation. These skills are involved in every activity a person does across their lifespan. Attention is described as the cognitive ability to focus on a task, issue, or object.
Cognitive functions is the main focus of the Allen Cognitive Disability Model, and there are three main concepts that make up this model. First, there's memory, as it is imperative for learning, decision making, and problem solving. It allows us to use past experiences to redirect present actions. Second is attention, which needs the mental capacity and flexible thinking towards a task or activity that is being performed. It also requires the ability to appropriately process information efficiently. The third important concept is executive functioning. EF involves a higher level cognitive ability to perform goal-oriented tasks by remembering instructions and managing multiple tasks. Collectively, these concepts or domains are necessary to understand how humans process, manage, and act on information. For instance, the lacing task-based assessment calls for an individual to use 2 needles and 2 strings with a cloth material and instructed to perform said stitch, all while each stitch complexity increases. Taking into account all of the key skills and components mentioned earlier and utilizing them as they are required to recognize, plan, sequence, and execute tasks for a successful feedback. The theorists and authors of the model are Claudia Allen, Sarah Austin, Sandra David, Catherine Earhart, Deanne McCraith, and Linda Williams. The origin of the Allen Cognitive Disability Model was from the field of occupational therapy. Claudia Allen noticed a trend in patients with cognitive limitations as they performed everyday tasks. The model is useful in occupational therapy because it provided a framework for evaluating clients with cognitive impairments and personalizes the interventions to aid in independence in daily activities.
The Allen Cognitive Disability Model can be applied to determine individual client functioning. Traditional OT cognitive behavioral models are focused on performance-based strategies to improve targeted cognitive deficits. In these approaches, intervention is directed toward function skills with arousal, orientation, perception, attention, problem solving, memory, and language use. Practitioners can utilize the Allen cognitive scale to identify the cognitive complexity of value activities, what the person needs and wants to do, to determine whether activities are likely to be done safely. This model can also be used to determine changes occurs in clients. Clients who present with significant confusion, agitation, language, and object recognition impairments will most likely be unable to follow the instructions of a standardized assessment. Simple functional performance-based tasks such as brushing teeth, washing hands, or buttering a slice of bread should be used when it's feasible. Such tasks can be broken down into small subcomponents or steps for systematic assessments. Compensatory techniques can also be used within the individual personal context for improved results. Changes for clients can also include support from a family or caregiver for optimal results in the task or activity. An individual can learn more about a client's functioning in the focus area of this model by having a description of the patient's level of occupational functioning and his or her ability to perform familiar activities. Systematically measure and collect objective data, organizing and synthesizing this data, providing targeted outcomes and creating goals, and determine procedures to measure progress. Some questions will be asked to our clients, like what are the level of support? What is the level of comfort they have with changes in their environment to facilitate mobility and safety. Describe how they perform their daily activities, such as preparing meals and personal hygiene.
The methods defined by this theory would include providing environmental modification or compensation, such as setting up supplies and tools for activities in a manner that allows for a person's disability. Therapists also use different assessment tools provided by the module on daily practice. Currently, there are 3 assessments used to help occupational therapists evaluate different aspects of human functioning, and they are the Allen Cognitive Level Screen, Routine Task Inventory, and the Allen Diagnostic Module. Throughout the years, practitioners have conducted research on the implementation of the Allen Cognitive Level Screen and the Cognitive Disability Model in the treatment of multiple conditions. The following articles are proof of the advantages of using the ACLS. The first study was created with the purpose of comparing the use of ACLS against other assessment tools when treating patients recovering from addiction. The results of the ACLS-5 were similar to the results from the other assessment tools, proving the effective use of the assessment to determine levels of cognition. The second study is about the accuracy of using ACLS in the treatment of patients that suffer from an acquired brain injury, in comparison to other assessment tools. The authors concluded that the use of the assessment facilitates time management during treatment, avoids physical or mental tardiness, and provides an accurate classification of functional cognition. The third article is a review of literature and supporting evidence of how the ACLS can be used for the treatment of mental disorders. The authors conducted thorough research on databases like Medline, ProQuest, and CineHealth with no date limits to find and organize information about the ACLS. The authors concluded that even though the use of ACLS is accurate and supports the results of tests as well as its implementation of treatment, more can be studied and researched. The article's reference on itself is a summary of information on database of the ACLS. All these articles and research proves the use of the Allen Cognitive Level Screen and its accuracy for treatment, being simple and easy to perform for both the patient and the practitioner.